Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the third session and the last session for tonight. We enjoyed actually the previous two sessions. It was an excellent lectures. I wish that you enjoy it also. Now we have very interesting session, which is about crystal-induced arthropathy, osteoarthritis, and COVID-19. We have the chairperson for this session, Dr. Ali Raheli. Dr. Ali Raheli is known to maybe all of you. He's a consultant rheumatologist, and he is the head section of rheumatology at Security Forces Hospital. Dr. Raheli had his postgraduate training from McMaster, and he's holding several positions, and he's now the scientific committee chairperson of the Saudi Adult Rheumatology Fellowship. Recently, he got a Master of Medical Education degree from King Saud bin Abdulaziz University, and just without also he's doing a lot of things regarding the fellowship program. He's a writer of MCQ and cases, belong to the examination bank. Just without further delay, the microphone for you, Dr. Ali.
Thank you very much for the attendees, and I want to just express my appreciations and thanks to yourself, Dr. Hanan, and the organizing committee, to the sponsoring company, Visors, and the supporting company, Synergy. This is the last sessions, and it will be the cherry on the cake. We really enjoyed the first sessions and the second sessions, but I promise this session is going to be a very, very interesting, a very important topics. Dr. Muhammad Attar is going to start to talk about crystal arthropathies and a very important subject, osteoarthritis. And the second part is going to be a Dr. Sultanas with, a news flash of COVID-19 and the arthritis disease. So I'll be more than happy to introduce the first sessions. Dr. Muhammad Attar is my friend, and we usually chat about lots of issues, including rheumatology. So it's my pleasure to introduce him. He is an internist and a rheumatology consultant at an important hospital in the western part of Saudi Arabia. It's Al Hada Military Hospitals. He is an internal medicine residency program director. He works very hard to get the center accredited for the adult rheumatology fellowship program. He finished part of his study at the University of Toronto and Kingston Universities, also in Ontario, Canada. Without further ado, it's going to be interesting to talk about crystal arthropathies and osteoarthritis. The mic is for you, Dr. Muhammad.
Thank you, Dr. Raheli. Thank you, Dr. Raheli, for this nice introduction. And I would like also to extend my thanks to the organizing committee for the kind invitation. So my job today is to review with you the recent abstracts and researches that I found has relevant to our daily practice in regards to crystal deposition, arthritis, and osteoarthritis. So these are my objectives for today. Obviously, there has been so many abstracts. It's a little bit over 100 in these two topics. However, I chose for you some of them that hopefully you'll find interesting, as I did. So the choice of these topics is completely personal. So forgive me if I did not mention your favorite topic. So I'll be starting with serum uric acid, and I'll be starting with this abstract that tries to find the relationship between serum urate and mortality. So a little bit of a background. So high serum uric acid has been associated and linked with multiple comorbidities, including hypertension, chronic kidney disease, obesity, and coronary vascular disease. So it has been replicated even in a biological model that hyperuricemia would be actually a cause for these comorbidities. Like it's more than an association in those studies. As well as hyperuricemia was the target of our management and treatment and to tackle. Also, low serum uric acid has been described to be having a relationship with dementia. So this is a topic that actually has a growing interest about the neurodegenerative diseases and high serum uric acid. So the scientists have found that, or they've thought that the uric acid might be a neuroprotective. It has an antioxidant property. And for that, hyperuricemia seems to lower the risk of having dementia or Parkinson, like the neurodegenerative problems. So I put for you here two recent results from two different cohorts that actually showed a little bit of a contradicting result. So to start with the French cohort, which included a little bit over 500 subjects, and they were followed for 13 years, 110 of these subjects developed dementia. Now, the result or the end result of this study was that dementia, especially vascular dementia, seems to be higher with hyperuricemia, which kind of contradict the original or the old thought. However, just to remind you, it's a vascular dementia. So it's not like the Alzheimer's disease. So it could be vascular dementia as part of coronary or cardiovascular disease. The second cohort is actually from a Swedish cohort. It's about 1,400 women that were followed for 44 years, and 320 of them developed dementia. So actually the finding of this study actually support the hypothesis that uric acid work as a protective rule for dementia. So I leave you with these two studies. I couldn't really come up with a clear answer in regarding the protectiveness of dementia. However, the most recent guidelines from the EULAR has suggested that low serum uric acid should be avoided. So you shouldn't really lower the serum uric acid to below 3 milligram per deciliter. So going back to this abstract, so basically they tried to examine the relationship between serum uric acid and all-cause and cause-specific mortality in a large cohort. So they actually used and examined the NHANES database, which is a National Health and Nutrition Examination Survey. They basically did a cross-section survey of a relatively large, nationally representative sample from the United States. So they have interviewed those patients, they did physical exam, and they included the patient where they have a serum uric acid at enrollment. And then they look as the outcome for all-cause mortality and then cause-specific mortality. So they divided them into two groups, male and female. So it's about 20,000 men that were followed for a median period of 13.7 years. It resulted into 5,700 deaths. And there was also 21,000 women that were followed for about, again, around the same period, a little bit longer, more than 14 years, the median time. And the deaths was about 5,000. So this is the baseline characteristic table. So basically, they've divided them according to the serum urate level. And as you can see, the relationship with the general characteristics. So as you have higher serum uric acid, if you go and see those above 8 milligram per deciliter, they tend to have higher body mass index, so they tend to be more obese. And also they tend to have more hypertension, which kind of reflects with what we have mentioned, that the relationship between hyperuricemia and these conditions, as well as you can find here that the estimated GFR was lower with chronic kidney disease and hypercholesterolemia. So it kind of reflects what we know. The new or the additional information that we got is that even those who have lower serum uric acid level, the percentage of patients who have diabetes was higher. So that was something that has been described before, but it has been replicated in this study as well. So this is a multivariable hazard ratio for all-cause and cause-specific mortality. So as we all know that all-cause, so the first row shows the all-cause mortality, which was about 52% higher in hyperuricemic group, those who have higher than 8 milligram per deciliter. The main reason for death in this group was cardiovascular causes and the chronic lower respiratory diseases. The interesting finding for me was that even though who have lower uric acid level, below 4 milligram per deciliter, they have a 33% increase of all-cause mortality. And if you go into details, you'll find that the major cause of them is diabetes. So the group have concluded that maybe the reason for the increasing mortality in this group was basically because of diabetes, because they tend to have a poorly controlled diabetes, and the hyperglycemia would be a uricosuric. We will give you a uricosuric effect, so they'll have lower uric acid level. So interestingly enough, that this finding was only found in men. However, women, they did not replicate the same finding. There was an Asian studies, they actually showed men and women. So again, I think it really depends on what ethnic group you're talking about. The last important information that they found lower mortality rate from Alzheimer's disease in the high serum uric acid group. So this is an inverse association, which kind of support the initial thought. Okay, so moving on, so I'll be more concentrating about gout, and I would like to kick it off with this abstract that talks about cardiovascular event associated with initiating alloprenol and febuxostat. Now, again, like this kind of, I'm repeating myself, so hyperuricemia has been well established. It has association with cardiovascular disease. Also, gout has been also shown that it has an effect. And actually, in some of these studies, they suggested that gout is an independent risk factor for cardiovascular disease. Most recently, we found that urate lowering therapy, febuxostat mostly, and also alloprenol, and that's why it has been mentioned at the CARES trial. So I'm going to touch upon it in a minute. So this is the initial thought on how this happens. So basically, the science behind it, that there's multiple studies suggested that if you have a hyperuricemia, that would increase the inflammation and cell proliferation, that leads to more proliferation at the interstitium of the kidney, and also the muscular layer of the vessels, which lead to an early stage of hypertension. Now, more recently, we have a lot of data suggested that, monosodium urate crystals is actually found at the cardiovascular system, which actually was visualized using a DECT scan. And as you can see, the green spot scattered points actually representing a monosodium urate crystal that is deposited at the wall of the ascending thoracic aorta and at the coronaries as well. So what can we make out of this? Is it like an innocent bystander that they just deposit as they deposited in other places? Or is it actually something that's going to be shown in the future, meaning that it will result into something more? So going back to the CARES study, as you can remember now, when they come up with febuxostat, there was a signal of increment of cardiovascular deaths. That's why the FDA and the EMA, they've compelled the manufacturers to actually do a safety study, and they included the febuxostat and alloprenol in this study. Now, the interesting finding was that febuxostat did actually show an increased rate of all-cause mortality, more specifically cardiovascular-related mortality, than alloprenol. So that has been already described. I won't really go into details. I mean, I know that CARES study has been published at 2018, but I'm not really going to go into the critique of this study. However, the interesting finding is that there was a Korean group that they have reanalyzed this study, and what they found was interesting. They found that at the time that you stop the urate lowering therapy, meaning alloprenol and febuxostat, there is an increased rate of all-cause deaths. So the group was saying, what's going on? I mean, why did this happen? And then they come up in their review that with a term called a cardiovascular gout attack. So the essential hypothesis about it is that what happened at the cardiovascular system, it kind of replicates what happens in the joint, meaning that for some reason the uric acid is being stable. When you start the treatment with urate lowering therapy, there will be a disturbance at the level of the uric acid, and that would result eventually into a gout attack, a cardiovascular gout attack. So they actually come up with this study that I found it quite interesting. So they try to investigate the association between cardiovascular event and the initiation of hypouricemic agent. So they actually tested the Korean National Health Insurance Service database, and they counted people who are, they call them an initiator, so they did not have any prior history of dispensing for about 60 months. And they would analyze them from 2012 to 2018, trying to find out if that finding that they found in the reanalysis of the CARES trial, did it replicate? And whole to behold, actually, they actually found that around the time that you start, first of all, their outcome was cardiovascular disease, which is an MI, ischemic stroke, and hemorrhagic stroke. So they found that repeatedly at the time of start of the urate-lowering therapy, people or patients tend to actually develop cardiovascular events. And also, if you can notice, there is a slight increase. I don't think it's statistically significant at the time of the stop. So what they come up with is that especially within the 30 days of initiation, cardiovascular event was associated with initiation with the with the urate-lowering therapy. So the conclusion that they come up with is that obviously when you start a hyperuricemic agent, you will be starting it to treat a recent gout attack. And that would make sense why the problem happens around 30 days before the beginning of the urate-lowering therapy. So actually, those might have a connection between the recent gout attack or fluctuation of the uric acid level resulting into cardiovascular event. Now, they come up with that this is actually supporting the cardiovascular gout attack, and maybe urate crystals could be considered as dyslipidemia as one of the risk factors for coronary vascular disease. So this study actually did establish the association, did not really establish a causation, but I think further studies would be quite interesting to support that idea. So more into therapeutics, unfortunately, we don't really have any, I would say, fun ideas or like any new therapy in regards to gout. However, we have quite more input from previous medications. So pegloticase, as you all know, it's a recombinant uricase enzyme that is attached to a polyethylene glycol. So in a simple word, it's a uricase that is pegulated. It's a pegulated uricase, and as you all know, that from simple science, that every mammals actually do have a uricase enzyme. So uricase enzyme is that whenever you reach to uric acid level, you had uricase enzyme to convert uric acid to allantoin. So allantoin is a highly soluble particle that would get eliminated easily. So that's why mammals, they wouldn't have gout. However, in humans, we don't really have the uricase enzyme. Some saying that the gene that is responsible for the uricase is deactivated, but I wouldn't go into that. And that's why we tend to have the uric acid. This is the particle that is not as soluble as the allantoin. Now, the ones who's sharing us among the mammalian family is the Dalmatian dog. So in case if you find a limping Dalmatian dog, probably he has gout, because they actually can develop gout. So, okay, so when we started the use of pegloticase, there was like two different patterns. So the first pattern, which is the gray line, the placebo, they didn't respond, the serum uric acid stayed high. And the red line, which is the people who started on pegloticase, that you can see the drop of their serum uric acid level. However, I should say that this percentage of the responder was about only 42%. There is another form, or there is another pattern of response, which is those who respond at the beginning and then they kind of lose the response. And I think we've all seen something like this. We kind of term it as secondary failure. So secondary failure is a term that we have known. And then obviously a further study did show that there is an evidence of immunogenicity that is resulted into a relationship between antibody development. So there is an anti-drug antibody to pegloticase leading to this phenomenon. And how did they overcome it? It's again the same thinking that all of you are sharing with me, probably by using an immune modulation. So this is actually from ACR of 2018. This is a case series of 9 sequential patients that Botson and Peterson, they actually started a methotrexate ahead before starting on pegloticase, and the result was quite significant in an improvement of the drug survival. So it actually the responder was about 80%. So since that time, multiple publications has been made and still ongoing, and they all trying to use a different sort of of an immune modulation. So methotrexate is still the big one. Some of them they're using it as an oral, some of them they're using it as a subcutaneous. They've used as a thioprin, they've used cyclosporin, they've used MMF, and also in this EULAR, there was one of the posters using flunamide. So the same concept. So this is one of the posters that was displayed, and what I would like to show you. So it's an open label study. It's not really a randomized controlled trial, but what you see is that the theme of the study is that for 4 months prior to starting of the pegloticase, they start the patient on methotrexate 15 milligram weekly, and then they would follow the duration of the period of its 24 weeks, which is 6 months. So the primary outcome is that you keep your serum uric acid level below 6 for 12 months, and for 6 months, and that actually was the case in about 80% of the time. So again, I think this is from the same group. They did it. It was a community practice. It was a retrospective where they looked into the records, and also the conclusion was that the response, if you use methotrexate and pegloticase in having a good response, is about 80% if you're using a methotrexate. And that kind of replicate the other case series. Again, I have to say that definitive randomization and double-blinded trial is recommended in order to actually make that concept. I still wonder, like for our part of the world, and like for my audience, is that do you guys use it? I know I don't use it. We don't really have it. It's not that applicable, but I think it's a growing. And again, especially they're using it for those who are refractory, not responder, those who has some sort of a intolerance to the traditional urate lowering therapy. So last point is that they actually did a database study, trends from 2014 to 2019 in the United States, and what they found is that 2015, about 2% of people used immune modulation in addition to pegloticase, and since 2018, since the case series, it went up to 15%. So I think they have changed their practice, or at least some of the rheumatologists in the United States changed their practice. Is it going to made itself to the recommendation, or is it only? So I think we're still going to find out the results of the randomized clinical trials. So last point about the gout, as you all know, treatment to target has been a strategy that has been entertained by many diseases, and who's more than gout that we can actually apply. I mean, we do have a number, so that's the target. It's not like rheumatoid arthritis where you actually develop a composite tool to reach that. Though the problem with gout adherence is that they actually counted up to 40% only people who are adherent using urate lowering therapy. I think it has to do something with the nature of the disease. So for that, there is multiple ideas on how they can overcome this gap. And this is actually a satisfaction survey of a Spanish study where they actually used nurses to follow up and monitor this disease. Partially, they actually come up from this study which was done in the UK in 2018. So they actually compare people who have the nurse-led follow-up or monitor instead of the GP monitor, and they found an excellent result with the nurse-led monitor. So they do the calls, they keep the levels, they keep an eye on the results, and they actually found a better adherence rate with this strategy, which actually makes me think, I know we still have difficulty on having a specialist nurse, but I think it's going to make a change and a difference for our population. And again, this is another way. So this is an application, a smartphone application, where they actually ask the participant to go daily, and then it asks them few questions in order to pick up those who has an actual flare, where the patient's going to receive phone calls. And it actually showed that this is a convenient way for those, especially that we are using our smartphones now every day. So there are some strategies that has been suggesting that if you are using a nurse-led care, I know that our practice is quite busy, so if you have a help from that aspect, might be something of use. In the state, they did a pharmacist-led care. I'm not quite sure if that's applicable in our part of the world. And the new technology. So there is a urate meter, which is like a glucometer where patients actually can check their uric acid, or the gout app. I think that we have to use some of the new strategies in order to improve the adherence. Now, shifting gears to another crystal, which is the CPPD crystal. So CPPD crystal, I found this study from the OMIRACT group. So the OMIRACT group, probably you know it from different publications. So this is the outcome measure, and they actually do an ultrasound. So they actually initiated a sub-task force in defining the CPPD crystals on ultrasound, and they conducted many studies. So during this study, what they did, so this is only examining they examining knee joints. They did not examine other joints. So they enrolled patients from, it's a multi-center trial. They enrolled patients who are going to undergo a knee arthroplasty, and they performed an ultrasound a day before it, and then they would put their results. And then they would retrieve the material from the surgery. So they would retrieve the menisci, they would retrieve the cartilage, the medial and lateral cartilage, and then they would run a microscopic study trying to evaluate if there is an evidence of crystal. So what they found is that if you, and I would just go into short, and probably I think this is really helpful for our sonographer or for rheumatologist who's doing ultrasound. If you are going to do an ultrasound, pick the medial side, look at the medial meniscus, look at the medial aspect of the cartilage, because it has the highest sensitivity, specificity, and positive predictive value. One thing about this study is that I don't really know what was their X-ray before it. So it will be interesting to find out what was their X-ray. Did it show actually a chondrocalcinosis or no? Okay, so moving to my last topic, which is about osteoarthritis. Again, there is many trials, but I actually tried to have the theme of hand OA for the sake of time. So the first trial was EULAR. EULAR is the colchicine in osteoarthritis. So they used colchicine for those patients who had hand OA. Now I have to say that they haven't really specified, do they mean an erosive hand OA, or do they mean just a simple OA with Hebriden's nodes and CMC OA? So they actually tried to use the colchicine, and their background is that colchicine works as an anti-inflammatory, and it might be able to reduce the accumulation of inorganic crystals in the joint. So they did a 12 weeks randomized double placebo-controlled trial. One part they actually received placebo, and the other part received the colchicine. And the primary outcome was the VAS pain score. And they looked at the other secondary outcomes. Bottom list, it did not help. It did not support the result of this study, did not support the use of colchicine as a treating symptom for osteoarthritis. Again, I have to say that this study did not really specify if they are dealing with erosive OA. This study, on the other hand, I think it's important. Now, we all living during this pandemic, and hydroxychloroquine was the famous player in this disease. So hydroxychloroquine, they have multiple studies. So the name of this study actually was the OA treat. So they're trying to figure out if hydroxychloroquine is helpful or not in erosive OA. Now, as we know, there are multiple back studies in the past that actually some of them suggesting the use of it, it's helpful, and the other ones did not. So what they did in this study, they actually used the hand OA, those who had inflammatory hand OA. They included the patient with erosive osteoarthritis. So they randomized the patients, and they started them in hydroxychloroquine or placebo. They allowed the background use of analgesics and non-steroidal. So they've been used for 52 weeks. And the result, so their primary outcome was the OSCAN score. So they used an OSCAN questionnaire, which actually kind of a questionnaire that measures the function and pain for the participants. And that was their primary outcome. So in short, they found that the hydroxychloroquine would help with ESR. So it actually lowers the ESR in the erosive, on the hydroxychloroquine arm. And it a little bit improved the morning stiffness, but it did nothing to function or pain. So this is kind of a negative study. But this actually was one of the large randomized placebo-controlled trials focusing on erosive OA. Now, would this actually change our practice? I don't know. I'm still using for hydroxychloroquine for patients with erosive OA for about 6 months. If they respond, then fine. Otherwise, then that's it. So I'm not quite sure. I'm not quite sure what to come up with it. I will leave it for discussion. Now, the last study that I'm going to touch upon is that they actually try to find an association between overweight, obesity, and hand OA. So they actually measured the BMI, the waist circumference, and they compare it with the results of the pain, the amount of pain they're having in their joints, which is the hands, knees, and feet. And they did an ultrasound trying to measure if there is any evidence of Doppler activity. The results of this study, it was a cross-sectional analysis for no hand cohort study. So it showed that those who had higher BMI and waist circumference, they tend to have more pain. And they concluded that the reason for the pain was mainly of a central pain sensitization. So it did not really have to do with inflammation, because the results of it was not correlated with inflammation. I guess I reached to an end at this point. And just to conclude and leave you with these thoughts. So low serum uric acid could be harmful as well. It's not only the high serum uric acid, still to be found. And whenever or before you actually start pegloticase, I think we should consider to start an immunomodulation to prevent the immunogenicity and the anti-drug antibodies. We actually, at this point of time, we have to have an open mind on using technology to improve adherence. And if you have to choose, choose the medial side. I don't know. I mean, I think that you can choose both sides, but I don't know. And then, yet, this is another disappointing study. It's a negative trials, plural, in hand OA. But again, this is, we still have to have hope. We still have to have another ideas. And yep, that's it. So thank you. And I will be taking any questions.
Thank you very much, Dr. Mohammed. Very informative. So I got lots of questions. So I'm gonna, just for the sake of time, picking some of these questions. The first question was sent talking about the thibixostats in the CARE trial. And there has been so many patients who dropped out, and as the mortality happened after the stopping is this thibixostat. So there are linking, is there's a relation between the thibixostat and cardiovascular disease. So the person who asked this question, he wants your opinion on this finding from the CARE study. So if you may answer that.
So right. So again, I actually refer you to read the CARE study. It was quite interesting. The point that there was a lot of backflows, which one of them, there was a drop rate. So the drop rate was quite significant in the febuxostat arm. So that would actually make you think is that if the results are actually from both arms, from the allopurinol and febuxostat, so make you think about the validity of the results. Again, the cause-specific mortality and the all-cause specific mortality was debatable a little bit. I would say that I mean, obviously even allopurinol has association with that. So if you have to use febuxostat, I think you still can use it, but with extreme caution, meaning that you have to bring patients now and then to monitor them. I don't think it's a no result that you don't use it for those who has cardiovascular risk factors, but you have to, if you have to use it, you have to use it carefully. And again, I mean, there is a lot of backflows, there is a lot of critiques about that study that we don't have really the time to discuss it.
Okay, thank you. The second question, which is maybe you mentioned part of it in one of the abstracts you presented. Somebody with a history of cardiovascular disease, coronary artery disease, and the person who put the question, he said, how low and how fast should we go with the upper limit of the uric acid level?
Right. So most of the abstracts or most of these studies, they've suggested 3 milligram per deciliter. So you don't go below 3 milligram per deciliter, but that for the part of how low, because you shouldn't go lower than 3 milligram per deciliter, though it will not be associated with cardiovascular risk per se, but as a safe level. So I think from 3 to 6 or 3 to 5, or sorry, yeah, 3 to 6 or 3 to 5 is going to be the level. Apart from that, how fast you go down, I don't think that we have any control on that. So if I understand the question right, on how fast we should drop the uric acid level, and I don't really know if that's something that we can control actually.
Okay, and the last questions before your time will be finished. Should we use methotrexate with big glycoticase to be effective? That's the questions was sent. So is it something really to be used?
Right. So actually, this specific topic received a quite of interest during this EULAR. Probably there were about 5 abstracts talking about the same problem. So what can I come up with is that yes, I think it's going to make its way in the future. I think it's going to change the practice. I mean, imagine if you're using pegloticase, which is a quite expensive drug, and then whenever you're using it, you are only having 42% responder, where the rest will lose it somewhere. So if you are using the methotrexate with it, actually it's going to sustain the response for longer duration. Now, for how long and how long you're going to keep it, this is a different issue. But to start with, I think in the future we're going to have more studies supporting the use of immune modulator rather than methotrexate alone.
Thank you very much, Dr. Muhammad. Very informative. So many interesting informations. We learned something really new. So I really appreciate what you've just told us. Thank you very much.
Thank you.
We're going to go to the next sessions, and I think nowadays no webinars is complete without introducing what's going on nowadays, the COVID-19. It is really very popular. It's almost daily on the last 3 months. So we are no different than the other. Actually, the COVID-19, they've took like at least 2 to 3 of our medications. So we should be the best people to talk about this nasty pandemic and how it is affecting the rheumatic disease. And who is best to talk about that? Dr. Sultana Abdulaziz. She is one of the senior consultants in Saudi Arabia. In particular, she's a consultant rheumatologist with multiple qualifications, Arab Jordanians board. And of course, she continued her graduation studies in rheumatology at King Faisal Specialist Hospital and Research Center. She's a very active lady, one of the people who founded the rheumatology sections and unit at King Faisal, at King Fahad Hospital in Jeddah. She worked very hard to participate in the educations of the fellows in the field of rheumatology, and she have done lots of publications and so many participations in the field of rheumatology. Dr. Sultana, she's gonna take us through how COVID-19 is related to rheumatic disease. And it's going to be next 25 minutes of lots of excitement. All of us are really eager to go ahead and listening to what she has to say. So without further ado, Dr. Sultana, you may start your talk.
Okay, thank you, Dr. Ali, for this nice introduction. I would like to thank Dr. Hanan Al-Rais, the president of the Saudi Society of Rheumatology, the organizing committee, the sponsoring company, for inviting me to present this interesting topic on COVID-19 and rheumatic disease. COVID-19 has been, since the end of 2019, a large impact has been done regarding the mortality and morbidity. And since March 11th, when the WHO declared that the COVID-19 was a pandemic, to date, more than 8 million cases has been reported worldwide, with the mortality rate nearly reaching 500,000 people. In Saudi Arabia, 141,000 cases have been reported, with a death of 1,000, more than 1,000 deaths have been reported. 80% of the cases with the SARS-CoV infected patients, they have a relatively mild course. 20% of the SARS-CoV infected patients have a severe course. There could be a fatality rate of 1 to 3%, which is different from one country to another. Rheumatic disease and musculoskeletal diseases are patients with autoimmune disease and patients who use immunosuppressive drugs could be at risk. Are they highly susceptible for SARS-CoV-2 infection? Do they have a worse course of COVID-19 infection? Today, my topic, I'll be covering the COVID-19 and update. What do COVID-19 data tell us so far regarding risk factors, EULAR provisional recommendations, points of difference between EULAR and ACR publications, the psychological impact of COVID-19 on inflammatory rheumatic disease. COVID-19 update. COVID-19 is an RNA virus and is a family of the coronaviruses, and it binds to the AC2 receptors that are highly abundantly available in the type 2 alveolar cells, interstitial epithelia, and vascular endothelium. You can see that the abundance of these receptors co-reflect the pathology, underlying pathology. That is the alveolar cells, you have pneumonitis with ARDS, intestinal epithelia leading to diarrhea, the vascular endothelium, which is leading to thrombosis. The virus, which is the SARS-CoV-2, and the result clinical illness we mentioned as the COVID-19. Same receptors are used as in the SARS-1, and terminologically, the name SARS-CoV-2 is the disease. Possible therapies that were used during SARS-CoV-1 have been the same used in SARS-CoV-2. COVID-19 is mutating, so the virulence and the transmission is unpredictable. The time of symptoms of severe coronavirus disease is that during the first 5 days is the incubation period. And once the onset of symptoms is the patient presents with fever, cough, fatigue, anorexia, myalgias, and diarrhea. This extends to a period of 7 days. The patient may resolve, or about 40% of these may rapidly deteriorate when become symptomatic, with presenting with hypoxia. When hypoxia is present, there is chest infiltrates on X-ray, and chest CT may show bilateral infiltrates. About 14% of them become symptomatic, leading to oxygen dependence, and a percent of 5% may end up with symptomatic critical illness. Severe COVID-19 infection, it can cause acute cardiac, kidney, and liver injury, cardiac arrhythmias, rhabdomyolysis, coagulopathy, and shock. These organ failures may be associated with cytokine release syndrome, characterized by high fevers, thrombocytopenia, hyperferritinemia, and elevation of transaminases and inflammatory markers. During the stages of the illness and the timing of therapy, during the first stage, this early infection is the viremic stage, which lasts about till the second stage into the pulmonary phase, when the patient starts to have shortness of breath. At this time, the viremia starts to decrease, and the host immune response is increasingly with the release of cytokines. In the early phase, as we said before, mild constituent symptoms with fever and dry cough, diarrhea, and headache. With the clinical signs with lymphopenia, increased thrombin time, measured D-dimer, and LDH are mildly elevated. As the disease progresses, with the hypoxia and shortness of breath, the POCO2, FiO2 is less than 300 millimeters of mercury. Chest X shows an abnormal X-ray imaging with elevated transaminases with low and normal procalcitonin. As the disease progresses further with hyperinflammatory state, there's ARDS and systemic inflammatory syndrome, shock, and cardiac failure. Elevated inflammatory markers are seen with sky-high CRP, LDH, interleukin-6, D-dimer, ferritin, troponin, as well as pro-BMT and elevation. The potential therapies as recommended is during the viremic phase to give antiviral therapy to suppress further release of cytokines and end organ damage. As during the hyperinflammatory state, it's indicated to give corticosteroids, human immunoglobulins, interleukin inhibitors, interleukin-6, interleukin-1 inhibitors, and JAK inhibitors. We don't have ATS randomized controlled trials. Still, they're ongoing to be later on in the coming months. We may have further results to be presented. What do COVID-19 data tell us so far regarding risk factors? In a prospective study in hospitalized patients from 6th of February to 19th of April, 20,000 patients were enrolled. There were 3,000 deaths. In a multivariate cross-proximal hazard was seen, and the hazard to death is showing that increasing age, male sex, cardiac disease, non-asthmatic pulmonary disease, obesity, dementia, and chronic renal disease were associated with death. In another study, which was including more than 70,000 patients with the age of more than 18 years, there were deaths about 5,000 cases, and the association was seen that the older age with, as well as obesity and social deprivation, being male, ethnicity of the male, blacks, Asian, and mixed were shown to have higher deaths, and as well as comorbidities like diabetes, severe asthma, cancer, kidney disease, neurological conditions. Interestingly, rheumatoid, SLE, psoriasis, organ transplant, and immunosuppressive drugs had a high death rate also. Regarding the hydroxychloroquine, and chloroquine has been associated with death and ventricular arrhythmias. This was reported in the Lancet that hydroxychloroquine, chloroquine with or without macrolides in the treatment of COVID-19. It was a multinational registry analysis which showed that those with the laboratory positive finding of SARS-CoV, they were given 4 treatment groups with chloroquine alone, chloroquine with a macrolide, hydroxychloroquine alone, or a chloroquine with a macrolide with a control group. It was associated that decrease in hospital survival and increase in frequency of ventricular arrhythmias was seen in the treatment groups when used in the COVID-19. The study was retracted. In June 15, the FDA revoked its emergency use authorization, stating that it was no longer reasonable to believe that the drug was effective against COVID-19, so that its benefits outweighed known potential risks. On 17th of June 2020, the WHO announced that the hydroxychloroquine arm of the Solidarity trial to find an effective COVID-19 treatment was being stopped. Based on the evidence from the Solidarity trial, as well as the UK recovery trial and the Cochrane review of other evidence, showed that hydroxychloroquine does not result in the reduction of mortality of the hospitalized COVID-19 patients when compared with standard of care. Does hydroxychloroquine be effective in asymptomatic patients? In a randomized controlled trial of hydroxychloroquine as a post-exposure prophylaxis for COVID-19, it was an RCT trial in which included 821 asymptomatic persons with high or moderate risk for exposure to SARS-CoV infection. 4 days after the exposure, hydroxychloroquine or placebo was given. It was seen that hydroxychloroquine did not prevent the occurrence of illness in comparison to the placebo. Regarding the rheumatic and musculoskeletal disorders, what are the risk factors for COVID-19 hospitalization patients with RMDs? This was published in the Annals of Rheumatic Disease by the COVID Global Rheumatology Alliance Registry, in which includes 40 countries in which EULAR is part of it. From Saudi Arabia, we have reported about 5 cases. Characteristic associated with hospitalization for COVID-19 in patients with people with traumatic disease. Data was presented from the COVID-19 Global Rheumatology Alliance physician-reported registry. 600 cases from 40 countries were reported. The baseline characteristics were the patients with those included with inflammatory traumatic disease, sick enough to have COVID-19 diagnosis or testing. Here, the females, 70% of them were females. The median age was 56. The most common rheumatological disorder, rheumatoid, hypertension, one of the common comorbidities. Never smoked, that is, was seen in 65%. Prednisolone was given in more than 10 milligrams in 64%. Hospitalization was seen in 46% of the patients, and 9% of the patients died. The limitations of the study is that it's a voluntary reported cases and does not capture all the rheumatic diseases cases with COVID-19. The data collection places limitations on causal conclusions and selection bias. The odds for hospitalization for COVID-19 by morbidity. Here we see that hypertension, lung disease, diabetes mellitus, and chronic renal failure were the odds for hospitalization, and doses of steroids at more than 10 milligrams associated hospitalization. Regarding the diagnosis, lupus was found to have an odds that was in the hospitalization, and it was seen as well as in vasculitis. Regarding medications, it was seen that the DMARDs are slightly elevated in the odds, but the good part is that the biological or the targeted therapy as well as the TNFs had a low rate of hospitalization, which is good news for our patients. In conclusion, the risk factors for hospitalization with rheumatic disease is largely similar to those without rheumatic diseases. Old age and comorbidities increase risk for hospitalization. Biological therapy and non-steroidals are not associated with high risk for hospitalization to COVID-19. Anti-TNF treatment was associated with decreased odds of hospitalization. Moderate to high dose of corticosteroids was associated with high risk of hospitalization. Last samples will allow us to study the disease, drugs, and comorbidities, and further studies with randomized controlled trials with further increase our knowledge. The COVID-19 and RMD recommendations. The EULAR recommendations of the provisional diagnosis of rheumatic disease and musculoskeletal disease in the context of the SARS-CoV. The task force include 22 members, and they met several times by video conferencing from April 2020. And the task force agreed on 5 overarching principles and 13 recommendations. It is published in the Annals of Rheumatic Disease, and I would recommend you to go through it in your leisure time. Just to highlight the overarching principles, the main ones: rheumatic disease patients do not have a higher risk of getting COVID infection. Rheumatologists should be involved in the management of management discussions, and in patients, as our patients are in great deal in need of the medication, and shortage of these drugs when they use in patients with COVID infections have a great shortage of the medication. So it's a social obligation that we get not to give the patients other than in need, other than in case of clinical trials. 13 recommendations with 4 themes. Over here, we see the first was the general measures and prevention of SARS-CoV infection, management of rheumatic diseases during a pandemic, management of rheumatic disease patients who have COVID-19, prevention of other pulmonary infections in RMD patients. In the general measures and prevention of SARS-CoV-2 infection, regular follow-up and according to the guidelines in your country should be followed. Those with no symptoms with COVID infection, they should continue the RMD treatment, the DMARDs, or the biological therapy. The team 2 was management of rheumatic heart disease, rheumatic musculoskeletal disease patients during the pandemic. The highlights are avoid visits to the hospital or office whenever it's possible, and remote monitoring is safe by telephone or a virtual clinic. If a visit is necessary, then it has to be taken in consideration. That is, caution should be taken by the physician as well as by the patient. If the patient has a history of contact to a COVID-19 patient, then the patient should be tested by PCR. Team 3, management of rheumatic disease, RMD rheumatic patients with COVID-19, glucocorticoid should be continued, but always go for the lowest possible dose. Mild symptoms of COVID-19, there's no consensus, and this should be decided by case basis. The rheumatologist in collaboration with the treating physician regarding the COVID infection. If the COVID infection is worsening, seek expert advice immediately. The internist, as well as the pulmonologist, or the intensivists who are experts in these fields, and follow the local treatment recommendation. Prevention of other pulmonary infections in RMD patients. Be aware of COVID-19 mimics. The patient may have allergy, or they could have sinusitis, these which could have reflux causing symptoms mimicking the COVID-19 infection. Vaccinations, especially the pneumococcal and influenza, should be updated. Prophylaxis, especially in those patients that are taking cyclophosphamide or glucocorticoids. The COVID-19 recommendations, what are the points of difference between the EULAR and the ACR publication? And this was presented with Prof. Ted Miklas in the EULAR this year. The differences are the authors, the setting, the audience, and the timing. With the ACR, it started before the EULAR guidelines. The difference was in the EULAR, it was the testing, where the EULAR recommended for the patient, if there is a contact, a PCR to be done. With mild COVID-19 infection, DMARD changes should be on a case-to-case basis, and updating vaccination was recommended in the EULAR guidelines. COVID-19, this was an abstract that was presented, the psychological impact of COVID-19 on inflammatory rheumatic disease and how to deal with it, by Rennie. It showed that the study examined the psychological impact of coronavirus in people with inflammatory rheumatic disease. This was an online survey, and 177 patients with inflammatory arthritis were enrolled. The mean age was 52 years, ranging from 26 to 76 years. It was shown that 53% of the inflammatory arthritis patients were worried about the coronavirus, and 70% perceived stress as a consequence of coronavirus. And they concluded that the RA patients were more worried about infections than the healthy individuals. And these abstracts that were presented, I would recommend that with the short of time that anybody interested to go through these abstracts. In conclusion, Risk factors for hospitalization with rheumatic disease is largely similar to those with rheumatic disease. With those without rheumatic disease, biological therapies and non-steroidals were not associated with high risk of hospitalization to COVID-19. Anti-TNF treatment was associated with decreased odds of hospitalization. Moderate to high dose of corticosteroids were associated with a high risk of hospitalization. Avoid visits to the hospital or office. Consider remote monitoring. Continue with glucocorticoids with the lowest dose possible. Manage patients with mild symptoms of COVID-19 on a case-by-case basis. Seek expert medical help and local guidance if COVID-19 symptoms are worsening. We have to update our recommendations as soon as any evidence is available. So with this, I would come to the end of my talk. Thank you for listening.
Thank you very much, Dr. Sultana. Lots of information. The questions are really pouring for you. So I'm gonna just like share with you these questions, and you can just answer them. One of the question is if a patient needed a biological therapy for uncontrolled disease, would you recommend to start it or postpone it? And nowadays, if somebody with in the era or the timing of COVID-19?
Well, with the main aim of our treatment is to keep the patient in low disease activity or in remission. If the patient is not controlled with her regular medications, then he has to be shifted to a medication that can be controlled. So if the DMARDs are not effective, or the one biologic that wasn't effective, we try to maximize his therapy. If it's not a way, it cannot be done, then it can't be changed to another biological therapy.
Okay. And what about the recommendations on IVIG in treating rheumatic disease, rheumatic patients with COVID-19? Did they mention anything? Have you come across any of the things in the recommendations regarding IVIG in rheumatic disease patients in particular?
Well, these are postulations that can be helpful, but we don't have randomized controlled trials to say that it's effective or it's in the recommendations.
Okay. I have so many questions about tislelizumab. Have you like come across that it might be useful other than cytokine storm in COVID-19 patients?
Well, I haven't come across, except for in cytokine release syndrome, in which they have a criteria that we can use it. That the patients, they have to be hypoxic, they have to have a PCO2 of less than a saturation of 93%, and then hyperferritinemia, LDH elevated, hyperferritinemia, elevated D-dimers, and IL-6 that is elevated. These are in context of a cytokine release syndrome. Apart from that, I have come across.
Okay, and this is a very a questions, and I thought somebody will ask. If not, then I will ask. But somebody sent this questions. In your recommendation, you said try your best to use the lowest possible dose of corticosteroids in somebody with COVID, and he is a rheumatic disease. But the person who sent this question, he said in those patients who have significant disease and intubated, dexamethasone was found to decrease the mortality, and they want, what is your comment on that? So too many informations in the recommendation said maybe steroids, maybe it's not recommended to be given in a higher dose, but this data contradict what is already has been recommended. So they want your comments on that.
Well, the thing is, it's been shown that once the patient reaches the level of ARDS and there is severe hypoxia, and already it has been used, steroids are being used. And then this is what the study that showed that critically ill patients, those are the ones that dexamethasone was given. So it's not for the viremia itself, they're giving for to decrease the inflammatory response and the cytokine release.
All right. Have you come across in the data you've went through the patients, rheumatic patients, going or contracting COVID-19 while on immunosuppressive medications? Did they say the rheumatic patient, they do better than the people, other type of patients, for example, because they are already on immunosuppressions, including IL-6 or other immunosuppressants, because of the phase of the inflammatory phase. So they are already suppressed. Did they mention about the outcome of this type of patients, the rheumatic patients?
Well, it's just, it has been seen that study that was mentioned by the Global Alliance, that the number of patients that were involved, they are not many. And those that were included, or they had hospitalization, or with death, they had comorbid illnesses, and they have a long disease history as such. So still, we don't have full randomized, these are observational studies. We don't have randomized studies to give a conclusive report.
Yeah, I think we are coming to the conclusions of our sessions, and I just want to again thanks Dr. Attar and of course Dr. Sultana for the important informations they shared with us. It was really interesting, and just wanna, before I head the microphone to Dr. Hanan Reis, don't forget the to fill the evaluations or the feedback to both the speakers as well as the content, inshallah, for future improvement in the next coming conferences. Dr. Hanan, the mic is yours, and thank you very much.
Yeah, thank you, Dr. Ali. Thank you, Dr. Sultania. Thank you, Dr. Muhammad, for the excellent session. I wish you enjoy it. Again, we need the evaluation. The good news that we have to start with around 500 attendees, and at the end of the session right now, though we are late, we have around 360 attendees with us. It's really is good. I wish that you enjoy all the sessions. Tomorrow we have a very exciting session about lupus, vasculitis, myopathy. So join us tomorrow at the same time, 7:15, and see you tomorrow, inshallah. Thank you again for all of you.
Okay, thank you.